It's good to see friends in the audience from history. There's a lot of old hobbling around veterinarians at this meeting, I know, and we're going to talk about things that are orthopedic a little bit. I might even touch just a brief minute on what we're doing in human medicine, but I'm going to talk about what I think is the future of platelet-rich plasma. And we'll talk about what PRP is first. Everybody here has probably used PRP or they've been injected with PRP. It's really the most common cellular therapy in vet medicine, published literally back in the 70s. Cooper, that was back when we were just in vet school, right? Yep, of course. And it's concentrated platelets, but it can be autologous, meaning it's your platelets, or it could be from a donor, and we'll talk about how those are different. Now, how does PRP really work? So we have a damaged endothelium in a patient. Maybe it was one of those patients that had the rollover back of the head and they've got an injury. Exposed collagen, platelets adhere, they activate, and they make a clot. That's the first thing we want PRP to do, right? It's the very first thing. But then they start releasing growth factors, which is what we're after in musculoskeletal repair and regeneration, for sure. It stimulates healing, attracts in stem cells. They actually produce a factor that attracts stem cells in, reduces inflammation. They produce antibacterial compounds, and it's these activated platelet granule dumped growth factors that we're trying to get. And there's hundreds of them. So we're trying to understand which ones work and how do they work, but plasma also has compounds in it that help us with healing. So let's talk about dose. So if I went around and we did a survey of 100 veterinarians who used PRP in horses for joints or soft tissue, and you asked them how many platelets they put in, what the dose is, they would tell you how many mils they put in, not how much drug. The drug is the platelet, and we miss that, I think, in regenerative medicine. It's really important. So it's the number of platelets times the volume, the number per mil times the volume. This is a drugstore. It's a little volume of drug, and so we need to know how much we're putting in, and you need to know you've got a suitable amount, or it's not going to function enough to signal and have the cell healing team work together. So the intra-articular dose is still argued. Why is it argued? Because almost all the data is published without characterization of the drug. People have a really nice study showing PRP works or it doesn't work, but they don't have a characterization of the drug they gave. It's a sad part of the scenario in the literature today. So I'm going to give you Bob Harman's thoughts on actual dose, and it can vary for sure, but the range is probably 2 billion to 4 billion per dose. And this is intra-articular dose, but it really depends on the severity, the joint size, for sure, if you're doing a stifle versus you're doing a much smaller joint, and the condition. So what about the uses of PRP? What are we doing in practice today? It's mostly musculoskeletal, but you get repair or regeneration of muscle, ligament, or tendon. It's the most common. Fracture repair is actually where it started in dental and human. Muscle inflammation and muscle tears certainly are a place we could consider. And of course, reducing the inflammation, the pain, and the damage going on in joints. We'll talk a little bit about wounds. So in musculoskeletal use, we're obviously we're going to do an aseptic technique, but, right, Cooper, needs to be ultrasound guided. People who think that they always hit the joint every time, if you don't get joint fluid, is the data in human is much better characterized. 50% of all joints injected by orthopedic surgeons are not in the joint. Really proven. So just be sure, use ultrasound. We have, this entire organization, ISELP, is about good diagnostics and using guidance from imaging, for sure. You can directly apply it to a surgical repair site, tears and wounds, and leuko-reduced products generally are used to reduce flare. If it's a contaminated wound, maybe you'd think about that differently. So what are the problems with autologous platelet-rich plasma? So you become a drug manufacturer. Cooper, I'm going to make you a drug manufacturer, okay? You didn't really want to be that when you got out of school, but you go, so you pick the donor status, right? You pick who's going to draw the blood. Maybe it's you, maybe it's a tech. You pick the kit components. You are the operator or doing the training, and you're responsible for the laboratory environment in which this is done. So From that, you get the yield, the dose, the potency, whether it's sterile, all of these which are unknown most of the time. So you're doing this in your lab, and you're being a drug manufacturer, maybe in the back of your truck, right? Maybe not such a good idea. The evolution of PRP has been from centrifuges, and those of you that know VetStem, we were in the gravity platelet-rich plasma device business for a while. This is no longer available, and I think this off-the-shelf allogeneic could be the future of where PRP treatment goes. This is coming soon. That's my FDA statement. So allogeneic means there's a donor. So healthy donors with known platelet count and function and disease screened. We have to disease screen them. We happen to use a USDA herd that already makes plasma products for the market. We use freeze-dried because we want to have it shelf stable so you don't have to haul around a liquid nitrogen canister or keep it in a -80. And it's leukoreduced, so we use an apheresis system which actually removes the white cells before we get into the manufacturing. And it's pooled. If you look at all the things that happen and all the proteins involved, every animal is different. When you pool 12 or 18 or 20 animals together, you stabilize that and you can measure it so you know what you've put in there. And we have a canine and an equine both. So why allogeneic? It's increased accessibility. At the time of diagnosis, you don't have to go make it, you don't have to go back to the office, you don't have to go to the lab and make it. Preserves the biologic activity shelf stable, like room temperature stable. Reduces the risk of bacterial contamination. Can still happen with a needle, right? Can still happen. But this is sterility tested before it gets shipped out. Requires no equipment or labor. No centrifuge, no setting the centrifuge, no changing the speed because you're going from IRAP to PRP to bone marrow aspirate, and they're all different. And really easy to store. You can keep it in your pocket, you can keep it in your truck. And it's standardized, again, for uniform outcomes. The data is just horrible. We don't know how to understand because we don't know what the potency is, we don't know the sterility, and we don't know the dose. So this is what the product looks like. It's in a 50 ml vial. You reconstitute with 8 mL of sterile water, and it's ready to go with 2 to 4 doses in a vial. We think we're going to have the FDA final sign-off right after the first of the year. In the meantime, we have a clinical program, if you want to participate in that, where you can access an early access program. If you will give us clinical data, and reasonable clinical data, you can access this for an at-cost price right now. So what's the product actually look like? It's freeze-dried, pooled, leukoreduced, and allogeneic, 500,000 platelets per microliter, 8 mL in a vial. We measured the platelet-derived growth factor, so we know the potency, and the total platelet dose, again, is 4 billion platelets in a vial. It's shelf-stable for up to 2 years. So once you got it on yourself, as long as you don't freeze it or stick it out in the sun on your dashboard, it's very stable, and it's got endotoxin tested, mycoplasma tested, and sterility tested. These are all the things we do. We do flow cytometry, we do moisture testing, we do sterility. All these are done before each lot, just exactly like a drug that you would get from Zoetis. We did a safety study to make sure this was not going to cause additional flares or problems. Everybody knows you stick a needle in the joint, you got a chance for a flare, right? It can happen. This was done at Auburn University. Dr. Lindsay Boone, she just presented at the Stable Talk this morning. The details of her study was blinded, placebo-controlled, where we used a saline injection to compare, and we did lameness exams, all the clinical pathology, and we had no adverse events. And so the safety looks very strong. That'll get published. That's been submitted to FDA already. So the conclusion is, again, of the safety study is joint flares you see usually within 72 hours. We measured at time 0 the same day in 4, 6, and 8 hours, and then we measured joint fluid at 7 days, and then we re-injected them again to see if we had an immune response. And this is what the product looks like right now, an at-cost deal. So Cooper, you can buy a whole case of them and use them in your practice, but we're required to get the data back for submission to FDA. You can email us at clindev@vetstem.com, and it's a really simple 2-page follow-up that you get from your from your patients and from the owners. And our booth is right outside of ISELP. Don't have the number. We're in this next room over, so please come by the booth. You can get the details. We will be publishing the safety study as well, and we've got ongoing efficacy studies. This should be just like all PRPs, except more stable, and so you know what you're putting in there. On the human side, we always say, know what's in the soup. We make lots of soup. Most of the time we don't know what's in there. We now know what's in the soup. Any questions? Cooper, of course.
So your donor, is it a consistent donor group, or do you have like a credible slew of horses? Or
there's about 50 horses in the herd, and we've got our identified 15 horses that go into when we make a batch. The horses can rotate in and out, but they're all donor screened in, disease screened in, closed colony, so they're not intermingled. So these aren't like, client horses, or it's not an ET herd. It's a USDA certified herd.
And then is that group, so you haven't had any issues with autoimmune response?
Yeah. So the question is about immune response. That's why we did that safety study where we gave them 2 weeks to see if they developed an immune response and re-inject them. And we don't suspect that would be the case because they're also blood typed. So you know which are the universal blood type horses. Yeah, so you don't end up with that. But we also have less than 0.01% red cells in the product and less than 1,500 white cells per microliter. So the apheresis system that puts the cells back in the horse and leaves us with the platelets assures that we don't have those in there. So it really reduces the chance of any kind of an immune reaction to a blood type. Yeah.
Once you've reconstituted the product, how long is it viable for?
Good. So the question is, when you reconstitute the product, which is, again, a 50 ml vial, 8 mils of sterile water, it takes about a minute for it to go into solution. And then right now we have a label claim it's good for 4 hours. I think it's probably good for 2 days, and we're doing a study with Cornell looking at how long it lasts. And if it's a sterile product, it should be okay for beyond that, but we won't, we'll say 4 hours now is our data. So good question, because people are going to,
Refrigerating it in the meantime?
you don't need to, you can keep it at room temp. Actually, platelets, there's a misnomer. Platelets really like to be at room temp or body temp, and when we cool and freeze them, people will freeze PRP. It shatters all the platelets, and then you don't really have intact membranes and a real PRP. You have a platelet lysate, which still has some growth factors in it for sure. But good question. All right. You've got a question, I know. I can just tell you have that.
I was asking the same question as
Yeah.
you asked, so.
Yeah, so it's important.
Because you got multiple doses in a vial.
You do, yeah, so how long can you keep it if you do it sterilely, obviously you could use it for a second animal. That's why we're trying to get at least a 12-hour claim or a 24-hour claim, so you could, reconstitute, use it. It's like a multi-dose vaccine vial. But it's a good question.
Potentially silly question. You've only got one site that you're working on.
Yep.
And 8 mils is a little bit too high a volume for that. Can you reconstitute it with less?
So the question is, can you reconstitute it with less sterile water so you have all the platelets in there in a smaller volume? The answer is yes, for sure you could do that. The answer to the question, have we done that and done any measurement studies with that? No, but you can put in that same amount of platelets, but that's a good and appropriate way to think about that. Yeah, good question. Yeah.
So if you don't have other horses to use it,
Yeah.
and is there a problem for you to use like a higher dose?
Yeah, so we know if you
don't
put,
wanna waste
yeah,
product.
the question is about higher dose. And the same question applies to cell therapy. So if you're doing stem cell therapy of some kind, like we provide adipose-derived stem cells, if you put too many of something in a small space, for example, in a tendon, you can get a problem because the cells die, there's too much, and there can be pressure problems putting too much in there. But dosing of platelets, people have gone, there's a lot of published data at higher doses than what we recommend with no safety issues. So the question is, are you wasting it? Now you're going to throw it away. Should I might as well just go ahead and put all of them in there? And if you're in a big joint, 8 mils is fine. But if you're in a smaller joint, it might be too much. Don't try to jam it in, because I think there's pressure problems that cause, anybody that's ever had their joint injected, probably Cooper, you probably had your joint injected, if there's a pressure pain effect as well. That goes away when it absorbs, for sure.
But a higher number of
yeah.
the
Higher number of platelets
wouldn't be a problem.
Yeah, so we have data in dog going to like 2 or 3x that. I don't think it adds you a lot of bang for your buck. It's like, more isn't always better. And especially with stem cells, where you've got a live living cell with a nucleus that's going to try to multiply, putting more in actually isn't better. But platelets don't have a nucleus. There's even an argument, are they really a cell or not? We call them a cell, or are they just a subcell because they don't have a nucleus? But they should be fine because they're going to dump those cytokines and growth factors.
A question about the cytokine angle too. Do you think we're going to be at a point where we're going to go beyond knowing how many platelets we're putting in to what cytokine panel, or what is our cytokine level?
Yeah.
The different types that are in there.
So the question is, which cytokines do we want,
right,
and are we going to be able to get there? So I think so. So we measure the common ones, PDGF, VEGF, the ones that we know sort of how they work, so we want to have that standardized. And then as we gain data in the industry over the coming years, we're going to know, boy, I put more in and it seemed to work better. And so now we know at least what we dosed with. So I think that will be useful. Individual cytokines, dosing with individual cytokines, I think, is going to be problematic. There's a symphony going on. These talk to each other for sure. So yeah, so it's, some are anti-inflammatory, some are actually pro-inflammatory for appropriate reasons. And it's why I'm a stem cell guy. I love PRP, it's really good, it has a really useful place. But the PRP will actually attract stem cells in from the local area because they're out around blood vessels, they're locally there. And the stem cell then manages which cytokines get turned on and off and continue to get produced. And the PRP cytokines are probably gone in 7 days, could be less, but they've jump-started the healing and they've called in the rest of the healing symphony and the other cells in there, the other immune cells, the true stem cells that are coming in trying to repair things. And they are exceedingly good at picking the right cytokine to make in response with their biosensors. They're really good. They're remarkably good. You can put a cytokine in a dish and stimulate the cell, and it knows exactly what you put in there and how much, and it turns on the balancing cytokine, and then when it's balanced, it turns off. It's self-adjusting. It's the only adaptive therapy we actually have in medicine. Good. Thanks, really appreciate you guys being here.